Well, then I'm going to hand it over to Jeff.
Perfect. Sounds good. Hello, everyone. Thanks for taking the time out to learn about HIV. We always love talking about it. I've been in the HIV clinic now almost 23 years. And as you know, HIV treatment has really evolved and changed over the last couple decades. I know we had one lecture already about antiretroviral therapy, and this is going to piggyback that and basically go over three case studies. Kind of the patients you'll see in clinic, patients that are what we call antiretroviral naive, meaning they've never taken treatment, and then someone who is what we're going to switch treatment on, which is we do occasionally as well. And obviously, if you have any questions or need clarification, just let me know.
Okay, great.
Right here, get started. Case one. That's a 24-year-old. Hey, guys, got a crowd here too. 24-year-old black male diagnosed with HIV last summer in August in Kansas. Risk factors include a boyfriend who was positive. He didn't receive any. I'm trying to get. I have some distractions in my setting here.
That's all right.
He didn't receive any HIV care until 2 weeks ago, and he has no HIV-related complications. Again, he's antiretroviral naive and asymptomatic, and he states he's ready to start HART, or ART as we call it now. Works full-time as a hairdresser, eats irregularly, often skips breakfast, often not at home until the late evening, and those kind of questions we ask. Maybe not necessarily on the first visit, but when you sit and talk with them about what treatment you want to start, you want to get some details like that because it could influence what treatment you want to start.
Okay.
Past medical history includes gonorrhea, urethritis, and genital HSV. History of penicillin rash. Medications is always key to get a full medication history, including over-the-counter medicines like antacids and H2 blockers or proton pump inhibitors that are often over the counter. But right now he's just taking acyclovir for herpes, PRN. Exam, pretty benign, like most patients with that are asymptomatic usually have pretty benign exam, just has some lymphadenopathy. Baseline lab, his CD4 count is 687, which is above 500, so in the normal range. Viral load is relatively low, 5,623 copies. He had a baseline resistance test called a genotype, and it shows full susceptibility, meaning he didn't have any significant mutations that could cause resistance to 3 classes of drugs. Our test doesn't test for integrase resistance at baseline or at all, but we normally don't test that at baseline. Learned about HLA-B5701 antigen last week, and we did that test on everyone at baseline, and his was negative. He's immune to Hep B and doesn't have hepatitis C. CBC and his liver and kidney function are normal. So the first question is antiretroviral treatment indicated?
Yeah.
Yes, right. And
Yes.
And this is a slide deck from the Department of Human Health Services website, and just cherry picked a few slides. And if you look in red, this is a key point is that HIV therapy is indicated for all patients now, and obviously those with low CD4 counts below 200 or have symptoms, it's it's even more urgent. And there's a number of reasons we need to start HART or recommend starting HIV therapy in everyone. Certainly sooner the better. You can preserve their immune system. Earlier the better. You preserve their immune system, the better. The higher your CD4 count is when you start treatment, the better immunologic response you're likely to get. The goal of therapy will be to reduce morbidity and mortality. Even those patients with high T cells and low viral loads that are not likely to progress over several years, they do, just because of immune stimulation, have increased inflammation and have increased risk for developing non-HIV related conditions like diabetes and non-AIDS defining malignancies. So that's a theoretical benefit. We know that when someone's virus is suppressed, they're less infectious, so they're less likely to transmit HIV. And another reason or rationale for treating folks sooner than we did, say, 10 years ago, even 5 years ago, is the medications are just as effective or even more effective and very well tolerated, fewer pills, fewer short-term and seems to be fewer long-term toxicities. And this slide didn't work. Oh, it's turned out in white. Yeah, it looks different from my Mac. So this was all the current HIV medicines, which you all learned last week. So we'll skip that slide. And this one as well. I have a duplicate slide that goes over some of this. But this slide basically, when you look at the treatment guidelines, we talked about it's changed and evolved over the years. Basically, we're in the era of integrase inhibitors. Just a few years ago, this slide would have been a little bit more complicated. It would be 2 nucleosides plus a non-nuke, or 2 nucleosides plus 2 different integrase inhibitors, or boosted protease inhibitors, and there was 2 options for that. And it's a lot more simplified now, and we'll go over some of that. So when we're looking at this patient to start treatment, a lot of times it comes down now to using which integrase inhibitor-based regimen. Using a protease inhibitor, darunavir, which is boosted by a drug called ritonavir or cobicistat. That's still an option, but more times than not, we're really likely, at least in our philosophy, is not using that, in part because it's fewer pills and even better tolerated regimen with integrase inhibitors. So one option is Triamec, and that contains abacavir, lamivudine, and integrase inhibitor called dolutegravir. So before you use that, you obviously want to know if their HLA test is negative. So if the antigen is negative, HLA B5701 antigen is negative, then Triamec is definitely an option. If that's positive, or you're interested in using or like to use a tenofovir-based regimen, it comes down to a couple different options. Up until a year ago, the 2 main options were Stribild, which has been out about 3 or 4 years now, and it contains tenofovir disoproxil fumarate, or TDF, what we now call the old tenofovir, and that's been around since 2002. Emtricitabine, L-vitagravir integrase inhibitor, and the pharmacokinetic enhancer cobicistat that slows down the metabolism of vitagravir and increases L-vitagravir levels, so otherwise it would be very potent at all. And that's 1 pill daily. The alternative, if we were going to use tenofovir, was Truvada, which is tenofovir emtricitabine, that's been around for quite a while, plus another integrase inhibitor, Tivicay, which is dolutegravir, or Icentrus, which is raltegravir, that's been out since 2007. That's twice a day, and Tivicay is once a day. So Tivicay or dolutegravir came out a couple of years ago. A lot of us were using Truvada and Tivicay, 2 pills once daily, or we use Stribild. Things have changed in the last year because development of the new version of tenofovir, which is tenofovir alafenamide fumarate, as you learned last week. You basically get lower concentrations of tenofovir. It's just as potent with less toxicity, so there's less kidney and bone toxicity risk. And it makes it a smaller pill as well, and still every bit as effective. So the new version of Stribild is Genvoya, which contains TAF, or tenofovir alafenamide, and the other 3 ingredients. And it's still once a day. The alternative to Truvada, the new version of tenofovir, is Descovy. And that's tenofovir or TAF plus emtricitabine. And that's still once a day. And then, of course, you could use it with raltegravir twice a day, or still use it with Tivicay once a day. And most of us are not going to use Icentrus twice a day, mainly because most patients are, prefer a once-a-day regimen. But there might be some situations you have to do that because of drug interactions. So again, if you're looking, so the options generally for integrase inhibitor will be the fixed-dose combination Triamec with abacavir, or if you're using tenofovir-based regimen, especially in patients that you would more than likely go with Genvoya or Descovy plus Tivicay. and we'll go over some of the pros and cons. And oftentimes in clinic, it comes down, most patients would prefer to take 1 pill a day, which means 1 less bottle to keep track of, 1 less copay. The more bottles you have, the more times you have a chance of a prescription not being filled on time or a delay in one and someone just taking one medicine and not the other. So anytime you have fixed dose combination like this, it tends to be helpful with adherence and it's certainly preferred by patients. So Genvoya, which again is 4 drugs, a fixed dose combination. It's bigger than Tylenol, it's smaller than Trimec. Atripla, which was a combination drug we've used for years, it's actually a little smaller than that. It is once daily, so 1 pill once daily. It should be taken with food. That's, ask that question if the patient is likely to take it with food. It doesn't have to be a full meal, just some food. You can use it even if they have some renal insufficiency. If their creatinine clearance is over 30, it's safe. Stribild, which was the original version, you shouldn't use if your creatinine clearance was below 50. Important fact is, or a key thing with Genvoya, that tenofovir is very active against Hep B and is approved for Hep B treatment as a preferred drug. FTC is not approved, but very active against Hep B. So you always want to know someone's Hep B status before you start treatment. There are some potential drug interactions due to the cobicistat, which again is a potent cytochrome P450 enzyme inhibitor. So much like the protease inhibitors, it can interact with statins, or a common drug that we see prescribed in our patients. Our patients becoming older, have more problems with dyslipidemia. So you have to always, be careful of that. There's a couple that are contraindicated, luvastatin and simvastatin, which, we don't use much anymore, but should really be avoided with cobicistat or any of the protease inhibitors, because you can get high levels and patient can be at increased risk for developing myopathy or liver toxicity. The steroid intranasal inhalers or intranasal inhalers or mouth inhalers for asthma or COPD can potentially interact with cobicistat or ritonavir, the protease inhibitor. So the steroids like fluticasone, which is Flonase, and some of the other ones like Nasonex and Nasacort can interact, and you can actually get higher levels of the steroid and develop Cushing's syndrome and some other toxicities. So you have to be careful with some of the inhaled and intranasal steroids as well. And there's basically one steroid that's the safest, and that's beclomethasone. So that's certainly negative for Genvoya. But younger patients or healthier patients not on a lot of medicine, it tends not to be an issue. As far as Trimec goes, it's once daily as well. It can be with or without food. It doesn't seem to affect the drug levels at all. There is a risk for a back-of-air hypersensitivity reaction, but you obviously wouldn't use this unless the patient's HLA testing is negative. The back-of-ear has been associated with cardiovascular disease, even heart attacks in some studies, or in one big study in particular, but not in all observational studies. The FDA even reviewed a lot of the trials and decided there was an increased risk. There's an ongoing debate about this. Particularly the guideline says that if someone has cardiac risk factors, use with caution. So if someone has hypertension, does that mean you should not use it? Not necessarily, but it's something to consider if you have other options. But for the most part, a lot of us don't really pay that much attention to it. So we don't necessarily believe that's a true risk. But if someone's already had a heart attack, they've never been on HIV medicine, they have numerous risk factors, it's truly unreasonable to use a tenofovir-based regimen. There's definitely fewer drug interactions because there's not a drug like cobicistat or ritonavir in that combination. There is one key interaction with metformin. It's not recommended you use more than, or at least start with more than 1,000 milligrams of metformin a day, because dolutegravir increases metformin levels. And we really haven't run into problems with that. Even people that are taking standard doses of metformin, but you should use with caution. differences, key things you need to think about if you're going to use Genvoya versus Triamec. In this patient's case, we elected to use Triamec. One daily is HLA negative. He has to eat every, meals regularly, HLA negative, and it's not a good option. So we just started that a couple weeks ago. Any question about those cases or the rationale for using that medicine?
Could you please elaborate on Genvoya with a patient who needs statins? Is it just not recommended or just for some statins?
It's used with caution if you look at the treatment guidelines of the DHHS HIV treatment guidelines. There's in the back of, or in the end of the document, there's a very good section where they go over the interactions. So basically, simvastatin and lovastatin are contraindicated. Never use those. If you use a drug, rosuvastatin, which is Crestor, or atorvastatin, which is Lipitor, you can use it, but they recommend it using lowest possible dose. So, so if you had a patient, you would normally use 20 milligrams or 40 milligrams of atorvastatin, start with 10, and, monitor labs like you normally would. Same thing with the rosuvastatin. And we rarely run into problems with that. Even though the levels do increase, the area curve can increase substantially, the peak levels increase substantially. We rarely do see liver toxicity. Really haven't seen myopathy from it either. So it's not contraindicated, it's just use of caution. Because certainly patients that have diabetes, statin, people with heart disease, we're usually on it. Pravastatin is the safest, although one of the weaker statins, so you tend to have to push the dose of that, which may could increase toxicity risk. So we tend to use atorvastatin or rosuvastatin, and especially if the patient's followed by another provider who's prescribing, like another PCP or specialist that's prescribing that, always make sure you go over what dose of the statins are on, because cardiologists and other specialists tend not to know about that interaction and will start the standard doses. Like someone who had a heart attack, they'll start 80 milligrams when that would be way too high. But again, we rarely run into problems. We do have to be cognizant about checking liver enzymes 4 weeks after starting probably, and again at 12 weeks, and asking the patient about muscle pain or weakness.
Okay. Thank you.
Yes.
Case 2. So it's this is another case from a couple weeks ago. A 32-year-old Hispanic male diagnosed with HIV 2 months ago, was via the health department. His risk factors were he had numerous partners within the last year, unprotected sex. He did have, he was HIV negative 2 or 3 years ago, so was likely infected in that time. He's antiretroviral naive, history of syphilis that was treated appropriately. Unlike the other patient, he is symptomatic. He's had recurrent thrush in the last 6 months, but nothing really else substantial or suspicious for opportunistic infection. And like the other patient, he is anxious to start therapy. He's on any medicine right now, other than nystatin that he was using for thrush. Baseline CD4 count is 314, so he's below 500. He's not considered to have AIDS because, again, he hasn't had an opportunistic infection, and his T cells are above 200. And his viral load is 64,000. Additional lab, his HLA antigen test is negative. A genotype or resistance test will show full susceptibility. He does have a slightly elevated AST and ALT, so liver enzymes are mildly elevated. Doesn't really have any evidence of cirrhosis on it by lab work. He has total billy is normal, albumin's normal, platelet count is normal, has normal kidney function. He doesn't have hepatitis C, but his hep B surface antigen is positive, and that's an error on the core antibody. That's positive as well, and that's positive for IgG. So he's someone who has been exposed to hepatitis B. More than likely has chronic hepatitis B. You can't really consider him to have chronic hep B or diagnose him with that until that's been positive for over 6 months, because 90% of people that are infected acutely will clear it. But chances are he's going to be, you cut the patient several months or years after being infected and gets chronic Hep B. He doesn't have any hepatitis B related symptoms, however. So in his case, and just like the other patient, you want to, look at all, look at his social history as far as his work and diet and those type of things before you start treatment. I didn't get the details about that on this patient, but let's say he's willing to, he can take anything you recommend. So again, he's HIV positive with a low T cell count. He's symptomatic. He probably has chronic Hep B. So one of the things we would do is check the E antigen, E antibody, Hep B viral load to confirm that he has active infection. Probably end up doing a liver ultrasound. But as far as his intraretrovirals, since he does have these recently had acute Hep B or probably has chronic Hep B, the preferred regimen would not be Triumeq. It would include something, a regimen that includes tenofovir, either the original version or the new version, TAF, due to chronic Hep B. So again, tenofovir is very active against Hep B, and even in patients that are mono-infected with Hep B, is the preferred drug to use. So those options include Stribild, which again is the version with the older tenofovir, then Genvoya, which has two drugs again that are active against tenofovir or against Hep B. You have should be T. I had these mixed up. That should be TAF, Intracitabine. So those are two active against Hep B. Elvitegravir and Cobicistat. An alternative would be using either Truvada or Descovy, both contain tenofovir, of course, plus either Tivicay or integrase inhibitor, or if you decided to use the protease inhibitor. Again, there's not many situations now that we would end up recommending that. Let's see. So that's again, having Hep B pushes you to starting a tenofovir-based regimen. As far as his outcome, Hep B viral load was 132 million, which is very high. E antigen is positive. He more likely is going to have chronic Hep B, and we started Genvoya. If there was a reason that you couldn't use Genvoya or a tenofovir-based regimen, let's say because of really poor kidney function, there are alternative options to use when someone has kidney disease, like the drug entecavir. So that will complicate. Having kidney disease will complicate HIV and Hep B treatment. But having Genvoya now that you can use with tenofovir that causes less kidney toxicity has helped a lot. We've even had some patients that were on alternative treatments that we can use tenofovir again now. So again, always want to know someone's Hep B status before you start treatment. So case 3 is a 57-year-old white female who was diagnosed with HIV in 2010. Her partner was HIV positive, and he later died of AIDS. She didn't have any history of IV drug use. She's done really well. She's been a follow-up clinic since 2012. She's only had some mild neuropathy that she had at baseline. Her baseline and pre-treatment CD4 count, which was around 2010, was 550, and a viral load of only 5,000. She started a tripla within about 6 months of CNS. So a tripla, as you might recall, is tenofovir, disoproxil, so the original version of tenofovir, emtricitabine, and the non-nuke, which is efavirenz. So her current CD4 count, after being on a tripla now for 6 years, is still high, 670, and she's been consistently had a low or undetectable viral load. She has a history of iron deficiency, anemia, and alcohol abuse, but she's sober for quite a while now. She's only taken a tripla and iron. So this was a routine visit last week, and she didn't have any complaints. And I was just kind of asking routine questions about her adherence. Even if patients are routinely undetectable, sometimes we get in the habit of just assuming they take their medicines well. But definitely, it's a need for every visit to address that, especially if you get a hint or a feeling that maybe they're struggling taking it. In this case, that's what happened. She said she rarely misses a dose of a tripla, and then she made a comment like sometimes she just wishes she could stop it altogether, or sometimes she feels like skipping a dose. In part because after all these years, she's still having trouble coping with her diagnosis. Doesn't have the best support system. She only has one person who knows her diagnosis, who her daughter who's having her own troubles. And then she mentioned one of the reasons she often didn't want to take it, even though she still would, is because she had some side effects that she attributed to atripla. So as many of you know, atripla, or the systemic component of atripla, has been associated with vivid dreams. And sometimes those are pleasant, sometimes they're not. She described them as being very unpleasant when she has them, even nightmares. She has them pretty frequently. She often wakes up in the morning, 8 hours after taking it, and feels a little bit hungover feeling for about 30 minutes to an hour. And that happens more times than not. If she has to get up early in the morning for for whatever reason, she feels really groggy. She hasn't really mentioned that before, and maybe I neglected to ask her, or she, kind of dismissed it, saying it's not a problem. But now with newer options, we start to think if we could actually switch her treatment. Whereas maybe 5 years ago, we'd say just kind of hang in there. She did not have any other symptoms of depression, because certainly some of the other things she said were alarming. She was willing to see a therapist, and she is willing to switch her treatment if we thought there was something that would work and that she would tolerate better. So this is what we call a switch case, and there's a number of studies over the years where you switch from one drug that's working, or one combination that's working, to another one. And they've done that with the newer therapy. So things to consider before switching is you want to know, as much as you can, what their treatment history has been. For example, she's only taken atripla, and we know she didn't have resistance at baseline. And we know that she's always been undetectable. So it's likely she doesn't have any resistant virus. Sometimes you'll see patients who don't remember what they've been on and know they failed treatment and didn't take medicines well. And, there's a possibility they would have some resistant virus that could complicate, switching, or complicate switching a regimen. You always want to know what someone's kidney function is, since we'll, potentially switch to a drug that has restrictions when you have kidney dysfunction. Less of an issue now with the new tenofovir, though. Obviously, you want to know their HLA status if you want to consider abacavir for a new part of a new regimen. If someone has chronic Hep B and you remove the drug tenofovir, let's say someone's intolerant to Sustiva and you switch atripla, but that contains tenofovir, and you remove that, they could have a flare of their chronic Hep B infection. So you always want to know someone's Hep B status before you start switch therapy. We even had patients in the past who chronic Hep B was controlled very well with tenofovir, but they developed kidney toxicity, and so we had to remove the tenofovir, but you had to replace tenofovir with a drug that is active against Hep B. And that's especially important in patients with cirrhosis, because that could, if they have a flare of Hep B, that could lead to decompensation, which is something you want to avoid. You want to address their cardiac risk factors, again, because abacavir is an option. But those are something hopefully we're trying to correct in every patient. Having them stop smoking, treating their hypertension, managing their diabetes, treating their lipids. You always want to feel for what does the patient want with her regimen. Sometimes patients are on multiple other drugs that are twice a day, so switching to a once-a-day pill is not a critical thing to them, because they're on other drugs that are twice a day. But majority of patients, if you ask them, are going to prefer to be on one pill a day if possible, especially if, like her, they've been on atripla. And now we have some options that we can do that, as you've already learned. So what could we switch her to? Well, certainly Trimec would be once a day. The Stribild, or the new version, Genvoya, would be once a day, and both should be effective. One we haven't talked about that you learned about last week is Conclara, or the new version of Odefsey. So Conclara contains tenofovir, disoproxil, emtricitabine, and rilpivirine, which is a non-nuke that came out in 2007. It's very well tolerated in patients that are naive to treatment. If patients have a high viral load over 100,000, it tends to be less effective. So that's going to be an issue in treatment-naive patients. It is acid labile, meaning that it really needs an acidic environment to absorb. So it should be taken with a full meal, like at least 400 calories, and it should avoid using H2 blockers or proton pump inhibitors at all. One of the other protease inhibitors, atazanavir, has similar restrictions, but there's some guidelines with using, like how much dose of a PPI you can use at the same time and get away and be fine. That's not really an option for piperine. They shouldn't be on any acid blocking medicines. And that's the same with the new version that contains tenofovir, which is Odefsey. But it's definitely can be once a day, and for patients that are healthy and don't have reflux and eat regularly, that's certainly an option. Another option maybe once a day would be more than one pill a day, though, would be Truvada or Descovy. That would be the easy change, just 2 pills per day. Or using even a protease inhibitor, which would be once a day, like using Descovy, the new version of tenofovir, and using a boosted protease inhibitor. And that can be as simple as 1 pill a day as well. So you have a number of options, but most patients that are going from 1 pill a day are going to prefer to go to 1 pill per day. And in her case, we switched a triplet to Trimec because she's HLA negative. She doesn't have chronic Hep B. It seemed like a good choice. There's no, Descovy would be an option as well. You could really pick one or the other. But in her case, she switched to Trimec, and as far as I know, is tolerating it well. And we expect her to, remain undetectable. I wouldn't even bother checking her viral load until 3 months later. You don't have to worry about checking it, a month later like you do after when you first start antiretroviral therapy. So that's the last case. So we had 2 naive cases, and again, more times than not, and this is some of my treatment bias or how I treat, and it comes down in most patients nowadays to Trimec or the new drug Descovy, which is available on Medicaid, on the HIV state program, and more on insurances, Medicare and private. And then switch trials can be switching someone from a successful regimen can be a little bit more complicated if they're more treatment experienced and have more comorbidities. But there's definitely even some of our sicker patients can get switched to some of the newer options, depending on what their treatment history and resistance history is. Do you have any questions at this point? Any comments or?
No, I don't. No, what do you?
My question may not be clinical, but more with eligibility in switching patients. Because if the patient, for example, if the patient is doing well on a medication, but for whatever reason may want to change other than something really clinical, having, reactions, or, this lady with vivid dreams or so on, and or maybe we'd want to switch for more compliance. Would there be a problem with ADAP and getting that patient eligible for another medication?
Oh, not at all. If they're on ADAP and you have to switch either because the patient wants to switch because, let's say, their partner is on Trimec and they want to be on the same medicine, or
right.
3 pills a day and they'd rather be on, they want to simplify, or someone has a toxicity or a side effect from a medicine, either real or perceived. The state program, you can always switch their medicine. You have to just send in there's something called a med pre-cert form that you check off what med you're going to switch them to, and it shouldn't ever be a problem. Yes, yeah, so okay. No, yeah. Unless you have to check out some drugs are like contraindicated, like if you checked off some kind of a funky regimen with drugs that are antagonistic, they would catch errors like that. But in general, they'll approve what you recommend.
Okay, great. Thank you. So actually, for the patient who's on ADAP, they probably have a better, more flexibility with managing their care with their medications than somebody who's privately insured. Because that could be a problem with privately insured patients, huh?
Absolutely, yeah, because ADAP, so ADAP is, Dr. Kaiser's here with me, and thanks to Dr. Kaiser and some other folks at ADAP, we always pretty much get the newer drugs earlier than Medicaid or private insurances. For example, we still, like Descovy, it's only been out 6 months, so sometimes you still have to get prior authorizations for, again, for private patients for Descovy. unless, and a lot of times I don't even bother, like if someone has normal kidney function and their insurance requires a prior authorization for Descovy, I just try to prescribe it again in 6 months. Unless they have kidney problems, you can't really probably justify it, they won't go for it. But that's less of a problem the longer it goes out, especially in the new year when the formularies get updated. And Medicaid's already caught up. Well, I think as far as I know, all the Medicaid cover the newer drugs. And that's always been the case with ADAP or the state program is, you know, the newer drugs we always have, they're always updating their formulary. There is a limit to it having 4 antiretrovirals, so occasionally we'll have someone who's on 5 or 6 and they've been on it for, and there's, you know, rationale for that. And we have cases like that, you have to, you know, justify it and write a letter, but that's a rare patient that will need something like that, and it's usually not much of an issue either.
That's great. That's good news. And I think, yeah, in getting their eligibility done, that could really increase their adherence in knowing that they have that autonomy, so to speak, in, you know, keeping ahead of their medications or being in charge of their medications.
Right, absolutely. And one thing I guess I should mention too, I do have a number of patients who, I mean, patients that I've been seeing for, or been in clinic for 20 years and, you know, have been on a number of regimens, and they'll come in, oh, I really want to be on the once a day pill that I've heard about. And now there's more and more, you know, 1 pill once a day. And a lot of those patients are just not good candidates, or I'd rather see some studies that kind of represent them before I switch, mainly because of past resistance. For example, a lot of patients that took AZT for years developed, selected for a number of mutations that could cause cross-resistance to tenofovir. And so if you switch to someone like say Descovy, tenofovir could be decreased susceptibility. They probably have resistance to tracidabine, and then all they're on is a fully active integrase inhibitor and maybe a partially active or resistant tenofovir, and they could be in trouble. Having said that, the integrase inhibitors are pretty darn potent and pretty forgiving as well. One of the drug company that markets and sells or made and markets darunavir, one of their things, and they're absolutely right about it, is boosted protease inhibitors are, for lack of a better word, more forgiving, or very forgiving, meaning patients that are very non-adherent and miss frequent doses. It's very difficult to develop resistance to the boosted PI just because they get such high drug levels. Now, they might develop resistance to 1 or 2 of the other components, but even the risk for developing resistance to the other 2 is lower. It actually protects the other drugs. But it turns out the integrase inhibitors are probably similar to that to some degree. It's more difficult to develop resistance. We have seen resistance to a few patients on integrase inhibitors, but not like the non-nukes, like Cystiva, where it has what we call the orogenic barrier, and patients who are not adherent can develop resistance relatively quickly and then develop resistance to the other drugs. So that's the advantage of integrase inhibitors, and they're probably more PI like that than, say, non-nukes. And that's another advantage of them and why we're feeling more comfortable switching people to them, even if they're treatment experienced. But anyone that has a complicated treatment history or toxicities, you know, you have to be careful before you switch to a 1 pill once a day base regimen. Any other questions or comments?
So far, no.
All right. Well, thank you for.
It's definitely good news for that patient who wants to get on board with the once-a-day pill after having, you know, having to manage this disease for years with the cocktails. That, you know, it's kind of bad news for them.
Absolutely. We have patients, one in particular I think of, that in the late 90s he was taking the original protease inhibitor, sequinavir, and another one at the same time, plus a non-nuke we don't use anymore. He was on like 30 pills a day, and now he's on like Truvada and a boosted PI, 2 pills a day, and you would never guess that would have happened 17 years ago.
So in terms of switching, sometimes it can be complicated if you're not sure. The rule of thumb would be to let them be if they're doing okay, all right? Now we're actively trying to get as many people on once-a-day regimens, or your one pill once a day, or maybe 2 pills once a day. But if you're not sure, I think when you start getting into this, what we should do is we should have some regular case conferences where you can discuss your difficult cases, and we can give you some advice on that. And just do it in this kind of format that we're doing right now.
Yeah, that's good.
Great.
So next week,
Thank you.
I'll be talking about opportunistic infections, and then the week
Okay.
after that, Samantha Robinson's going to talk about case management. And then we've got several other things potentially scheduled, which we're still working on, which we haven't got to yet, but we're getting through it. So it's coming along. And then I guess you're going to be hearing from TRG. You know, we're very happy to have you come down and follow us around, and I know they would like you to do it too. So you know, when we can get all of those details worked out, we'd love to have you come to Galveston.
Right. I'll definitely work with Samantha to get those dates set.
Yeah, and you know, and it doesn't have to be a big road trip where everybody at the same time. I mean, we can accommodate. In fact, it'd probably be less disruptive for you and less disruptive for us if you know, maybe 1 or 2 and kind of do your thing. You know, one person follow Jeff around, somebody else to do the pharmacist. You know, at various times, and it'll you can still, that way you don't have to close your clinic.
Right.
Well, that was our plan. We were just going to take off and hit the beach, but
Okay, well, if that's what you want to do, that's fine too. You know, we can do that too. However you want to do it, we're open to it. You know, it's just I got a very, I don't want to say officious email, but a concerned email. How are things going? And it's like, well, you know, we've already started our lecture series. We're talking about getting people down here, so. You know, I think
Right.
it's going fine. TRG's in a rush because they really want
Right.
to get all the patients transferred, and I
Right.
understand where they're coming from with
right.
All
that.
right.
Okay, well,
Thank you.
see you next week.
Thank you.
All right. Thanks again.
That's great. I actually was having an inspiration while we were sitting.
Oh, really?
I think we should do like a monthly thing. We'll start with them,
Oh,
okay?
yeah.
And only 15 minutes. We'll meet to broadcast.